Yeah, we all in this room are devoting our professional lives, I guess, to reducing health inequalities. Not as if we're not trying. But I do think that's appreciated by people we're trying to help. It's all a bit top down and us looking in, and we need to get in there and look out.
And welcome to this panel where we will consider how, in an increasingly connected world where we have technologies linking one another and the organised efforts of society potentially across health and social care, how in that data-intensive world with tipping points of AI do we bake in greater prevention to make our services more sustainable in health and care and greater fairness, the equity of those services. It's a particular interest to me. So I'm Iain Buchan. I'm Associate Pro-Vice Chancellor for Innovation at the University of Liverpool. And I'm a public health physician with the NHS, with local government, and I'm a data scientist. I released my first medical software in 1987. And with that engineering mindset, I've watched with great interest the uses of data through successive governments' policies, that pendulum swinging between centralisation, decentralisation, the struggles to manage a health service where more than 90% of costs are fixed and needs are going up. So how has data been used to improve patient care and population health in tandem? I had the great privilege to work with colleagues, some of them here, in pandemic responses back to the front line of public health in COVID-19. And this country, including Liverpool's mass testing, managed to pull off some of the world's leading interventions to really write the playbook for fair and timely responses. If we can do that in a pandemic, what can we do in the build of integrated care systems? And that's what we'll consider. I'd like to invite my panelists to introduce themselves and say what really grabs them about this agenda. Rowan.
Good afternoon, everybody. My name's Rowan Pritchard-Jones. I'm a plastic reconstructive surgeon in my NHS life. I specialise in cancer, and my academic life works in cancer as well as population health. And having been the medical director of St Helens and Knowsley NHS Trust down on Merseyside, appointed 12 weeks before COVID arrived. That was quite a roller coaster through those years. I now find myself as the medical director of NHS Cheshire and Merseyside. So we are one of the 42 integrated care systems. We're the second biggest, snugged up next to our friends in Manchester. And it's a challenging setup. We were 9 CCGs, now 9 different places, 22 trusts, 350 GP practices and 1,400 care homes. We have a population with some of the deepest deprivation that is out there. And our mission as an integrated care system is to look at doing this stuff differently, about being really precise in our interventions with those who need it most, and taking a population, a community with us on that journey to empower them with their health and provide the right support where it's needed, especially in difficult times as the NHS is now facing. Thank you.
Thanks, Rowan. Joe.
Afternoon, everyone. I'm Joe Rafferty. I'm the Chief Executive of Mersey NHS Trust in Merseyside, so part of the ICB that Rowan is Medical Director and on the board of the ICB. Right at the start of COVID, one of the tasks I'll say I volunteered for it, but I was asked in a way that I couldn't turn it down, was to lead in Cheshire and Merseyside what we call the out-of-hospital cell. So all responses to COVID that didn't involve hospital-based responses. And on the very first day I said, well, okay, let's get the information on the table. And guess what? There was really very little connected information I could make sense of. I think I rang Iain pretty quickly after that and said, you know, isn't it funny how we've come from a world that is, in NHS terms, beautifully set up to do episodic care, although it's creaking at the edges a bit now. But actually, we moved from a history of doing into the episodic care period of the NHS from a period of infectious diseases. And here we were with a new infectious disease, and actually we weren't able in digital terms, in data terms, to particularly respond to that in an agile way. So I was very struck by your experience of where is the infection? And I mean, I think it was the very first question I asked Iain is, where is COVID-19? We know people with it are in hospital, but where are the people who are getting it, and what processes are they moving through, and so on. So you know, we've worked together now for since that, Iain and I, to connect lots of data across our systems, general practice, social care, ambulance, not just the sort of traditional NHS stuff. And I suppose what I'm really concluding is, if we're going to get to a place where we can tackle health inequalities, then we've got to do that through the connected data, and then using that connected data to make more agile decisions through integrated care systems in the way that Rowan has spoken about.
Thanks, Geoff.
That's Iain. So I'm Geoff Little. Until very recently, I was the Chief Executive of Bury Council, one of the 10 in Greater Manchester. I was also what they call the place-based lead for the integrated care system for Greater Manchester in Bury. And therefore I was accountable both to the local authority and to the NHS through the Integrated Care Board. And before that, when Bury CCG still existed, I was the Chief Officer for the CCG, as well as being Chief Executive of the Council. Prior to that, I worked in Manchester City Council for 23 years and had a part to play in the Greater Manchester Devolution Deal and its implementation across Greater Manchester and in Manchester particularly. And then 3 weeks ago, yesterday, I retired, which makes me wonder why I'm still doing things like this, but here we are. I'm partly doing things like this because I am passionate about the role of a partnership between the National Health Service and local democracy in reducing health inequalities. All my 44-year experience tells me that that is at the centre of the way forward if we are serious about reducing health and wider inequalities. And I've been reflecting on that quite a lot, as you'd imagine, as I came to the end of my career. And I think the answer lies at various levels. We've got to innovate and improve prevention and early intervention at the interface between public services and public systems with the people and communities that experience those levels of deprivation and inequality. We've got to really understand those places, not only through data, although that's important, but also through direct experience and contact with and listening to people in those communities. I think we've got to stop telling people in those communities how to behave, how to live their lives, and listen to those communities slightly more, and help them help us to change our public systems, our public services, so it makes their opportunities to grow, to become successful in their lives, that more likely to happen. And at that level, you see the reality of the interconnectedness of these problems. An obvious solution would be to enable more people in these communities to access good jobs, high quality jobs, with good wages, stable jobs. But of course, we all know one of the two biggest barriers to people getting good jobs is ill health, the other being education and skills. So these are not linear solutions. And they are solutions that need to be tailored to the individual people and places where the inequalities are deepest and widest. I've also had a lot of involvement in creating integrated public services at a neighbourhood level. So integrated teams of community health services, adult social care, community mental health services, working with local GPs and the wider primary care system to integrate services so that the experience of services at the front line is much more effective, less chaos, more integrated services, more coordination, and much better experience for people being cared for in the community, their carers, their wider families, and the neighbours around them. But I believe we can go much further with that model and start to connect to other public services to address those wider determinants of ill health at the most granular level, at a micro level. And I believe, therefore, we have an opportunity to grow from integrated health and care services to integrated public services to have an impact on deprivation and therefore health inequalities. And finally, at the institutional level, at the level of local authorities in particular, where you can have regeneration frameworks of planning to engage people in communities on their agendas so they benefit from physical and economic regeneration. How we, at that level, get provider partnerships. Now we've done away with, hopefully, the commissioner-provider split, get providers from local government, the voluntary sector, and of course, health providers in joint teams, driving innovation, maintaining innovation until it becomes mainstreamed. I think that is where a lot of these solutions on prevention lie. And then, of course, at the integrated care system level, where essentially you've got to get the balance right between integrated care boards and their accountability to NHS, England and government, with local government through integrated care partnerships and their accountability to local people through democracy, local democracy. That two-way accountability, I think, sounds very technical and boring, but I think it is long-term the answer to the levels of inequality in this country that have been too great for too long. So I'm really passionate in believing that integrated care systems, new though they are a fundamental part of the way forward. And I'm interested in understanding how we make the best of this opportunity and how we improve integrated care systems as they develop to have an impact on population health as well as the essentials of NHS services.
Thanks, Geoff. So we have a number of questions submitted by yourselves, by the panel, folks online. I'm going to start with one of your questions, Rowan, to Joe. Is research still relevant in integrated care systems?
It's a great question. I think in our integrated care system, given that we spent time interviewing for an associate director of research, the answer is fundamentally yes. But in a broader context, Iain, I think you can answer that question in a number of ways. I think where most ICBs are at the minute is head down, dealing with lots of urgent stuff, and I think there's a real risk that urgent drives out the important, it drives out a longer term perspective. And for me, at least, one element of having an active and lively research agenda at an ICB level is it begins to tease us into thinking about how it could be rather than how it just is as it stands at the minute. I think research itself, particularly if it hooks into innovation, into new business partnerships, into inward investment, actually addresses the point I think that Geoff was making there. Why do, in some of our cities, our university students come, get educated and then leave and go to the Golden Triangle or wherever it is to go? Why do kids who come out of school, struggle to find a route into and a way into the sort of modern 21st digital industries? Because actually there are no employers in our communities doing those sorts of things. So I think it's relevant and important in the immediate, in that it will teach us, as my experience with you has been, that we can take research but build out of it rapid learning cycles, which means that NHS organisations like my own can use evidence in a really agile way to say, let's do less of that and do more of other types of work. So as an organisation, we're trying to recalibrate ourselves from the whole world of see and treat, which every NHS organisation in the world is, in the country, is focused down on, to more predict and prevent in the way that Geoff has talked about. And that some of that is data and analytically driven, some of it's relationship driven and better insight driven. So for me, it's a big yes. The benefits that come off it, better connected data, better insights, more agile ways to move. You know, the great holy grail, the cost of healthcare is no longer affordable, actually, in the trajectory it's on. And we've got to use research insights and so on to begin to loop around the other side and create something that creates wholesale value for the population.
Wise words.
It's just to add to that, and therefore the ambition for us in Cheshire and Merseyside, quite apart from what we can deliver in terms of the knowledge, is thinking very much around what is the experience we give for our patients. We've got some of the most challenged groups of patients in terms of need for research, whether that's cardiovascular disease or cancer. But because we've got a lot of specialist trusts, some of our patients might end up taking 6 different buses to get to attend a research appointment. And so now that we have an integrated care system, one of the things that Joe and I, that we've recently appointed to, are directors of research who I am tasking with creating an integrated research system. That patients can access studies close to home, that we start to then get into some of the inequalities of patients being able to access that. We get better information, we solve the problems that our region really needs solving. And we then are also attracting the partners to work with because we create this rich network to be able to make research happen in a highly functional environment. And I know that cancer is being discussed later this afternoon as well. I've just come off, so I chair skin cancer nationally for NCRI, and at the chairs meeting, there are studies coming in now that are prepared to open up in multiple parts for the delivery arm, whilst there's one central hospital coordinating. And that is what our patients deserve by way of a research function as well. Thanks, Iain.
Thanks.
Thanks, Iain. I think there's never been a more important time for evaluation of integrated care systems as they start out. In Greater Manchester, we had a quite in-depth evaluation by University of Manchester into Greater Manchester healthcare devolution. And that concluded, at least in its first phase of reporting, that in the first 5 years of devolution, life expectancy as a measure of health inequalities in Greater Manchester fared better than the rest of England outside of London. There were technical reasons why London wasn't included, which I didn't fully understand, but for the rest of the country, GM did better. I think what actually happened was England suffered worsening life expectancy during that period, and Greater Manchester was in some way protected from that worsening by what? Was it devolution that did it? Or was it that we'd had 20, 30 years of partnership working on regeneration and economic development and making sure that residents benefit from that regeneration? So we need more research and understanding to understand here what is the real impact of ICSs on not only health inequalities, but wider inequalities at a place level. And I think the time is to do that, because this will move on. And before we know where we are, we will move to the next version of this. I also think that as we move on, we need to make sure there's more of a learning culture in how we work together. In Greater Manchester, I'll be the first to admit, during those 5 years of devolution, we weren't great at learning from each other across 10 areas. Some of us went this far, others that far, and others less far. Why weren't we levelling up all the time? Why aren't we learning more effectively from ICS to ICS? And I know people do network, but is that structured enough? If this is going to be a national shift in devolution and delegation that's meant to have an impact on health inequalities, are we really learning from each other as we go? And finally, I think it's a cultural thing for me here. We've got to be prepared to be wrong and be honest about it and learn from those mistakes. And if the accountability systems are too top down, then that will drive out that fearless innovation and the ability to be honest when you're wrong and learn from it and spread that learning. So there's a cultural aspect as well, I think.
Yeah, it's been humbling to see the cultural shift in universities, a generation of new researchers, bright young people who felt a pull into the values and the data and the social impact in COVID-19 responses. And I see a tighter coupling of research for innovation that I think describes what you've all reflected. So I'm going to put your question to the other members of the panel now, Geoff. On inequality specifically, are there any powers that you think that we need to imbue in the coupling of the National Health Service and local government and their academic partners? Are there any powers and duties that we need to put in place to evolve integrated care systems? Joe, I'm going to put this to you, because I know you've been involved in the Hewitt Review.
I mean, can I start above integrated healthcare systems? I think there is a real requirement, if we're going to tackle health inequalities, to start across government, because frequently the allocation of funding from government down into the councils, as we've seen, you know, the disastrous funding, quite frankly, or underfunding of councils in the past decade, and the continuing shift in funding in healthcare, and the general lack of integration across those big silos in government. I just looked quickly, 200 billion in health and social care, 75 billion in education, 45 billion in industry and business, and 35 billion in transport. Now, if you just had an integrated approach across government, you could work that money really, really differently. And I think certainly when I talk to ICB colleagues in my own ICB and others, one of the things that people reflect is the way that the different departments of government drop down into a local context and make it almost impossible to create some sensible approach to the spend of money. I mean, the Better Care Fund is probably one of those examples where, I mean, several years in, I still don't know what happens with it. I know, and I'm not sure anybody really knows if we're working that in a way, because DCLG and health and care had slightly different perspectives on what should or could or might happen. So I do think, Iain, we can try and create all sorts of connections locally to have them subverted by some big issues nationally. So, I mean, if we're going to think about the powers, that's where I would start. And I hope that as ICBs get skin in the game and wind in their wings, or whatever the analogy would be, that they will work collectively to influence the central government that way, rather than sort of run off to attempt to do their own things.
So if we have the ability, if we have the powers and the interconnectivity between organizational accountability and workflow to become more preventive, how then do we use our data? We have a question here from Monique Duffy-Brogan, Chief Digital and Information Officer from Pennine Care NHS Trust, asking a question. I think it's in your wheelhouse, Rowan. How do we get more predictive? So if we're going to prevent, how do we use our data to move upstream? Where do we move upstream? How do we use those data and technologies?
It's got to be the right place to look, hasn't it? We know for any individual, their journey into ill health, 90% of it happens before they ever see a doctor. It's formed by the housing they live in, the education they've had, the job, the genes they've inherited from their parents, the diet they take, the choices around smoking and all of that. Only 10% of health ends up in front of the doctor, at which point we're playing catch up. So I'm very proud to be part of the NHS, one of the best known acronyms that trips off our tongue, the National Health Service. The reality is, it is a national sickness service. It is reactive, and at times, too late in the way it reacts. So we must start to get upstream. So the practical way for me of thinking about this is we've got a building narrative in Cheshire, Merseyside about intelligence into action. There's loads of data. Heard lots and lots about data. Data's great. But the World Health Organization doesn't often have a short definition, but it does on this. Health intelligence is data that you can action. So we must turn our intelligence into that response, therefore. So where we want to work, particularly with local authorities, we've won a grant recently that is allowing our local authorities to partner with us and say, who is living in a cold home? Who is living in a mouldy home? Look at the tragic events of a 3-year-old not so far from here. Our housing teams are now saying, on the housing list, I asked them, do you know the risk that the people who are in your housing list, in that bucket of people, are living with? And they said, no. Well, why don't we put them in a line now based on that health risk? Why are we not first lifting out of those cold, mouldy homes those patients living with COPD, asthma or cardiovascular disease, who are at a higher risk of an emergency admission because of that part of their life in that environment? We can do that now. That programme is live. In Knowsley today, our respiratory teams are calling to those most vulnerable patients because they now know who they are because of the data we hold. And when that data becomes health intelligence that leads to meaningful action for those individuals, a precise way, it's good value. It massively improves their outcomes. And crucially, we talked about culture. Let's get that civic agreement now that our health intelligence is something we are proud to see used on our behalf. I don't know about Big Brother being a demonic type thing, and I'm not one for paternalistic medicine, but I think the idea of fraternalistic medicine is one that could work, and we can create an agreement, a covenant with our communities that says, let us work with you to best use what we know to improve your opportunities of good health. And maybe we're in with a chance of not just being a national sickness service.
A covenant to bridge the data action gap for our communities. That's a very profound concept, right? Geoff, I want to put a question to you from Chris Mailer from Novartis. It says, how can we use our voluntary sector in bridging some of these gaps?
Well, clearly the voluntary sector is going to be at the very heart of the action on the ground. And let me start at the community end of voluntary community. I said that before, we need to be focused on our improvement at the interface between the people and the communities experience the worst health inequalities and public systems and services. And that at that interface, you'll normally find a whole range of, not voluntary organisations, but community organisers, community activists, people who are trying to give people on the ground, local residents, communities of identity, some voice and some agency in affecting the conditions that they live in. And it's not for me to get anywhere near politics on this, but I think there's got to be an acceptance that a lot of people in the most deprived parts of this country feel as if they are not being listened to, that the normal systems in this country have not actually helped them change their own conditions. And we do need to use community activists, community organisers, small community groups at a micro level to really help us connect to people on the ground and say, actually, there is hope. And we do want to understand this from your point of view, to have some humility, to have some empathy with the people we're trying to help here. Yeah, we all in this room are devoting our professional lives, I guess, to reducing health inequalities. It's not as if we're not trying. But I don't think that's appreciated by people we're trying to help. It's all a bit top down and us looking in, and we need to get in there and look out. Professor Jenny Poppe from Lancaster is brilliant on all this stuff, that you really need to understand that interface properly if you're going to make this work. And I therefore think the community and the voluntary community is so important. Now, my belief in local democracy and marrying that up with the accountability of the NHS to NHS England and Parliament, and those two bits of accountability come together, is really important here. Because ward councillors, executive councillors in the local authority have real political power, need not to be bypassed in that relationship if this is going to work. And then, of course, you think about how that really impacts on health inequalities. And there's a guy called Ken Masser, who until recently was doing great work in Rosendale, just north of Greater Manchester. The GM moving process in Greater Manchester has done much the same work, galvanising GP practices, primary school teachers, community organisations, to develop a movement of movements. People who are really not top down, telling people, get more exercise, eat more healthily, but actually generating social movements within communities. Now, I know that sounds somewhat woolly, but actually there is science around that. There are people that think about that and the science of it and how you do it in a rigorous way. And then, of course, when you think about the service providing voluntary sector, the great opportunity we've got, and now we are, moving away from commissioner-provider splits, is to bring the voluntary sector as an equal provider partner alongside NHS provider partners and local government and other public sector partners as a shared partner in co-designing innovation, being part of the delivery, not just us innovating over here and then asking them to deliver something for us. They have to be an equal partner from the get-go.
Hope, profoundly important and hard to measure. For the things we can measure, I'll give this one last question. Joe, Fiona Costello asks here from Orca, looking at lots of different technologies. How do we go beyond the crude measures? How do we maximize value for our communities? What is the approach of an integrated care system to technology value?
I think that's a very interesting question. I mean, I would hope that our ICBs will start to ask a question about, why is it that innovations, I don't know what the figure is, it takes something like 15 years to get from an innovative stage to an application stage. And there's something very wrong in a system where it takes that long to, maximise the benefit for the population of something that looks like it's promised. So it would be important, I think, for ICBs to have a view on how do they reduce the cycle time of that. That might be that, there's a better risk-taking sort of appetite around taking new things and getting them implemented and led in. I think it's really important that we maybe focus less on innovation. Don't mean focus less on innovation, but we seem to be describing successful innovation as lots of new things, as opposed to that thing about being able to take innovations and turn them into practical change on the ground. I think ICBs, integrated care systems, have a real opportunity there because there is no commissioning, but there has to be payment systems. And one of the things that really stops, in my long experience, of getting new things led down into whether it's a voluntary sector organisation, an NHS one, is that thing about our inability to stop doing things that are not very effective, because that's hard. And how do we, under a new payment model, start to allocate very differently and move our money around the system? And that's one of those powers things, by the way, that absolutely does need addressed in this sort of approach. And I suppose lastly, I think Geoff addressed it in his answer about the voluntary sector. We need to work out how to have our communities, or work with our communities, so that innovation is pulled rather than innovation is pushed on. And then people get suspicious about profit motives and all of those sorts of things. So I don't think it's a sort of simple silver bullet approach to this, but I think the answer lies somewhere in starting to address the different tensions at every fit.
Thanks, Joe. I think time has probably defeated us unless Angela says our next speaker's not arrived. Okay? That would be wonderful. I mean, what you've all described so far, if we could wire that up as a national grid of value optimizing data, technologies, people, and communities self-organizing through all of the sectors in new kind of accountability and value chains, that's profoundly important for the world. As a researcher, now I don't see that in other parts of the world. So this is a duty we have looking outwards. Colleagues, are there any questions from the floor on this topic?
Thank you very much. I'm Tom Fellows. I'm from Nuffield Health. So we're a not-for-profit charity, independent sector group of hospitals, gyms. We provide a number of elective care services in support of the elective recovery programme, as well as gyms and programmes that we offer free of charge for people as a charity. You've mentioned a lot about voluntary sector, about public health, about local government, about the NHS. For me, these are all taxpayer-funded institutions. How can organisations like mine, whether you call us a not-for-profit, a charity, or even an independent sector for-profit organisations that also have ideas, programmes, how can we start to contribute to some of these broader conversations rather than just waiting for a procurement process to kick off or to be invited along? Really be keen to be invited into more of these conversations and looking for how we do that.
That's a great question. And co-creation, not just post hoc social prescribing, but getting all of the strengths in our amazing communities in at the very early ideation stage. Rowan.
So I suspect you're probably ahead of the curve in some of the stuff that I want to see us make happen. So you've heard me talk already about getting our intelligence into action and dealing with the so what question. That's the crucial bit. So I know that we can bring forward a whole load of use cases to identify patients and parts of our community who have most to gain by some very specific support, particularly whilst they're waiting for their surgery even. Look at the size of our waiting lists. We are now in certainly one of our trusts and getting ready to open across all 11, prehabilitating patients, supporting them to wait well. Perhaps some of them are heading into your gym this afternoon, who knows? But when I looked at all of the assets that we've got across voluntary sector, charitable sector, Cheshire and Merseyside, 15,000 charities. They've each been born out of a need, people with personal experience that's driven them to put something together. And my question now is, how do we start to build a rich network so that we can deal with the so what? Because we can't necessarily throw health money at these problems, and perhaps we shouldn't. The social prescribing side of this could be hugely powerful, and the work of Nuffield is a fabulous case in point. So when I say you're ahead of the curve, you've already got that network because of the way Nuffield works that we should be tapping into and thinking about how it can support some of these programs. So I don't doubt you and I will be catching up later.
Great, thank you.
I mean, just to say, I think when I describe the voluntary sector, particularly the service providing end of the voluntary sector, I should have said including the independent sector and social enterprise. And in Greater Manchester, there is inevitably a protocol and a forum, etc. It is designed to engage the independent sector and social enterprise as well as the voluntary sector. And it's early days, but the doors are open, I believe. And there will be innovation and creativity in your organisation and organisations like yours, and we've got to be receptive to those ideas. And we've got to work together and say, well, how do you apply those? Well, have the biggest impact on prevention, where the prevention is most needed.
Thanks, Geoff. Any more questions? Gentleman here.
Hi, thank you. So I'm Andrew Wardley. I'm Chief Executive Officer of Outreach Research Innovation Group. I'm very interested in the question about research. So we've seen, unfortunately, because of COVID, that the NHR infrastructure has virtually collapsed. There's parts of the UK, for instance, Hull, that are not having any cancer trials open in breast cancer, which is perhaps historically been the driving area of cancer research. know you have your aspirations to have your skin cancer trial open across the whole of this network. How do you think that will happen, given that each individual trust is failing in its R&D setup time? That cancer, as we know, suffers from very small numbers compared to other disease areas. And a wider question, the question that the NHS only invests less than 1% of its whole budget in research, trying to find answers to the questions that are fundamental. Every area of medicine must have a question for every patient. We must try and answer those questions, but we're just not doing it at the moment.
Thank you, Andrew. So some profoundly important points, and I'm mindful that we've had wonderful cancer research in this country. It's a very highly funded area, appropriately so. But we've seen massive increase in need in areas that are not very well funded in research. We had a trebling of our young people around Liverpool suffering mental health crises. And there isn't a prolific evidence base. There's not that pipeline of research and service development and innovation and responding to society's escalating needs with a lack of understanding about the underlying mechanisms, but a need to respond to the variations in risk and outcomes at the front line. And Joe, you've had to take some decisions as a chief executive about how to build a research base in a big mental health organization.
Yeah. I mean, it's a really important point you make. But you know, I work in a part of the NHS where traditionally, historically, generationally, it's been underfunded. And what's really clear is many of the treatment opportunities we have in mental health, some of them belong in the 19th century, never mind the 20th century. And certainly, you know, we're short on the 21st century applications. And we've had to work really hard to establish, between my trust and the University of Liverpool and with the blessing of our ICB, a mental health research for innovation centre, which is really about addressing some of the points, albeit for mental health rather than cancer in this instance, about how do we get many more people wanting to pull and advocate for trials? How do we shorten the gap between trials and real-world change for patients? How do we move away from historic trial structures and move to being able to look at the rhythms of life? So if you're somebody with, you know, hard to treat depression, you know, maybe we can be measuring how far you walk every day as a real measure of how much your life improves, how well you eat every day, how well you hydrate every day. Stuff that we can now do using wearables and connecting data in a really different type of way. And I say all this in a world where I think every affected cancer patient in this country, we spend something like £280 on research. For every affected person with mental illness, we spend less than £9, you know, despite the fact that the biggest single disability debt in society is for people with mental illness. So I'm not sure if I'm answering your question, but I think what I'm saying here is there's a massive set of opportunities if we can harness our thinking around the research agenda in a different way. And certainly work we've been doing is about beginning to think about how again, we connect that data differently. So COPD, Rowan has referenced that earlier, or the respiratory disease. But we know that 30% of people on our books, my own trust books with COPD, 30% of those people have severe or moderate depression. We can treat the COPD brilliantly and ignore the mental health, and we'll not improve their quality of life. Might stop them dying from COPD, but we won't improve their quality of life. So there's a really big opportunity for us here to begin to think about being much more agile around research. As we stratify patients for access to trials, we can be really clever about that and create those populations, which I think will become very attractive to industry side partners, because in the work that we've done in establishing the mental health piece, we talked to hundreds of industry side partners, and the one thing they said was, we want to be able to recruit well, we want the data on patients to be pretty straight, and wouldn't it be great if we stopped arguing about what an outcome is from an academic perspective and just put some real world markers on it? So it's a great question, and there's a lot of opportunity for it.
To answer directly the bit on cancer, we faced some challenges in Cheshire and Merseyside with this. So I started a year ago a working group with NIHR. So I have a role leading plastic surgery and skin cancer with NIHR as well. And we've agreed now that we need to create a far more agile workforce that can respond to the needs of this, so that trusts are working together and collaborating with their research workforce, that our research teams are trained not just in a disease-specific area, but can cross-cover and support other trials as they come along, so we can be far more agile. And it's actually that collaborative effort that is changing the way we deliver the research and is therefore leading us towards an integrated research system. The other bit to get right, and Joe, you've just touched on this, it's awful, isn't it, that trusts and R&D departments open the brown envelope like this when they see what their funding allocation is. Well, I tell you what, you start getting homegrown research, you start attracting other finance into that, working directly with the pharma who are saying, well, can you help us identify and get a study set up quickly? Good for the patients, and the money flows with it. Let's stop being dependent on the money that is flowing centrally to make our research happen, and instead become far more self-sufficient, because we have the right offering delivered consistently in a joined up way. That way, that innovation piece can suddenly take off, because there is resource available to then go do it and be prepared to fail within some good governance, but learn fast, fail fast, and on you go. And it's trying to get that virtuous cycle built that lifts us out of that difficult place. Not easy, but I think it's worth the effort.
Thanks, Ron. A question here. Would you like to come up?
I am Yolanda Managola, Chancellor in the City of Salford, and I'm doing my master's course in health and social care. So I've heard a lot about everything you've mentioned, but I've not heard anything about patients. I don't know where patient comes in all these. And I think that patients are being left at the side. Patients are not being heard. We've got cases where patients are being failed with long appointment times, not being listened properly. I'm referring to a specific case of cancer patient who's been seeing a GP. We also mentioned that patients, our experience are like 95%. Some of our experience has passed like in family, where we live and our condition, everything. But 5% is in the hand of health and social care professional. So I think that's where we are being failed the most, because that specific patient went to see the GP because of different symptoms they're experiencing. For I think 1 year, they didn't take that seriously until they decided to do some tests, and then she was referred to the Christies to be told that you've got 3 years to live. That was last year. That specific lady is going to be buried tomorrow, which means those 3 years that she was supposed to live went through in the hand of professionals who were not able to detect what she was going through, because patients are not being heard. What everything we've been mentioning here is good, how to tackle inequality, but in practice, inequality is still there. We are still experiencing it. What is going on? How long are we going to be talking about inequality without actually tackling and dealing with inequalities? Thank you.
Thanks, Yolanda. Very, very powerful words and very important that I really feel. As someone who was born and bred in Liverpool and grieves still that a third of children are born in poverty in Liverpool, and that 16 times more children are taken into care. than the national average. It was really eye-opening to open the first civic data cooperative, turning around to our residents and saying, we have ideas in professional services of how to use data to make services more preventive and fairer. But what do you think? What are your values? Bring your creativity to the table. And there's a scheme that you can see on civicdatacooperative.com online of what's your problem. And that invites members of the public, small businesses, charities, small organizations, bigger organizations, just come forward and say, how do you want to innovate with data and social connections as well as technical connections? And one of those small organizations, Koala, is dedicated to pulling families back from the brink of having their kids taken into care. Peer support, the circular economy, supporting families with complex lives. And I know, Joe, you've invested in the complex lives work, and you have, Rowan, in the ICB, and you've spoken, Geoff, about many of these topics. We feel them deeply.
Yeah, I think we've talked a lot about outcomes and inequalities and outcomes, but you're absolutely right. At the same time, every day, there is massive inequality in the access to health and care services, and that is by ethnicity and by deprivation. And where there's overlap, it's compounded. There's also inequality not only in the access to services, but the experience of services. So what you've said, I think, is recognised and has to be dealt with here and now. You can't wait 5, 10, 15 years to, prevention to have its impact. You've got to be acting on access, experience here and now. And that's written into the job description of integrated care systems. So we've got to make sure that we have that balance right. We are focused on prevention and early intervention, but at the same time, focused here and now on the quality of service experienced by people day in, day out in our services. And that's a tension that I think all integrated care boards and integrated care partnerships are feeling at this moment. I'd also just go back to COVID and just comment on what we all saw. It wasn't just that a national pandemic, a pandemic had been dealt with nationally, impacted communities very differently. And we saw that particularly where you had areas of deprivation overlaid with areas of high concentrations of Black and Asian communities. The impact was very different. It was worse. But so too was our response. Our response had to very quickly adjust to those realities on the ground. And we did different things in those communities. If we do that in a COVID emergency, why can't we do that day in, day out? So I agree with you. We've got to be focused on those realities here and now, not just the prevention side.
So our patients experience systems, but we often manage those systems through organizations. And patients have pathways through organizations. And we're not carrying through that joint accountability or design at the moment. So I think Yolanda's point and our challenge is really well made. Are there any other questions? Gentleman here, thank you.
My name is Mahesh Nirmalan. I work for the university and the MFT Trust. Isn't it the case that this whole discussion about health inequalities and the focus on health inequalities is a bit of a distraction? Because if you are a poor person, you get bad experience with the legal system, you get bad experience with the cultural space, you get bad experience with the health space, transport space. So the common denominator there is actually poverty. So isn't it better that if the effort is put into addressing poverty and investing in that space, rather than talking and putting money into expensive systems, IT solutions, trying to understand why poor people get a bad deal in health? I mean, if you're poor, you'll get a bad deal across the space. I just think that this is a bit of a red herring for a few of us to have some nice, interesting discussions and produce some interesting papers. Isn't it the case?
So this is the eternal debate in public health. I feel that very much as a public health physician. How do we build the opportunities for the next generation in social well-being, social fabric, and the economy. And £13 billion a year is lost to the economy from poor mental health. There's a circularity in all of this. And we absolutely have to have joined up NHS, local government. If our NHS can create jobs in the economy through the digital sector, through the life sciences sector, this is another route to tackling bringing out of poverty some of our most challenged communities who have some of the richest lived experiences, to enrich those technologies, to improve those trials. And this is a joined up system that you've pointed to.
I think it's a great point. You're absolutely right, but I think we've got to go back to the quality of political discourse. I think we can, members of this panel, we can contribute, as Iain said, through anchor institutions, better employment, thinking about, as this thing's called, programming equity and programming prevention, rather than sort of retrospectively this thing called inequality, which is the stuff that's happened that we didn't intend to happen because we didn't spend our money very sensibly in the first place. But actually poverty, we need to go back, I think, to political discourse. We need to be as disgusted by poverty as we are by the length of waiting lists or the quality of some of our buildings. And that's not just a public sector thing. That's why we have elections. And Yolanda, it's exactly the same point I'd make to the critical things that you said. The poorest people in our society are the most disadvantaged around their political voice as well. And they don't feel listened to. Geoff referenced this, but I think it was a poll I read yesterday that clearly shows in the most disadvantaged communities, 30% of people just don't think there's any point in engaging in the political process. I know it's more of a statement than an answer, but this thing about poverty needs to become a political activism issue, and we need to be disgusted by it in the same way that we're disgusted by lots of things, apparently.
I agree with Joe, but I don't think that action on health inequalities is a distraction from poverty. I think they are inextricably linked. Poor health is a cause of poverty. Poverty is a cause of ill health. You have to do both at the same time, and all of that entails. I think what Joe has said is right. Ultimately, this is about power and the degree to which people have agency over their own lives. And I'm not an expert in this. There's a guy called Pritchard, who I've been listening to recently. He's doing great work on this. And some of the research says quite starkly, lack of control equals ill health. So it's not just involving people to get better outcomes from your interventions, although it will, but the actual act of involving people in poor communities, deprived communities, in of itself will support their health improvement. So I think, whilst you're right, we've got to tackle ill health as part of that wider attack on poverty in this country. The two go together in my mind.
Control over your own life. One of the most important determinants of health is an individual, a family, and a community. And those communities now have new agency as we form integrated care systems from boards and partnerships. And our residents, those remarkable creative opportunities to rethink this, to blend what we have now with what we could have if we generate that hope from this kind of conversation. So I think time has now defeated us.
Just say one more thing. Especially we don't see integrated healthcare and social care because we're still struggling to get registered with dentists, GPs, or many services. What is integrated services for us? Because we don't see it. We're still struggling, so we don't understand what is it. Can we find any way, like a clear way for people to understand what is integrated care system, and then people feel that, and then people live that? Thank you.
So very quickly, because I know you need to move on. There is a huge piece to do to make it feel relevant to our communities. I agree with you entirely. What our communities expect, rightly, is that when they have ill health, they can see a doctor. And when that doctor needs to get them into hospital, the hospital is expecting them and can see them quickly. And when they've completed that treatment, they can get safely back into their community with the right setup and community care for them to then recover. Right now, since the inception of the NHS, those have lived in silos, but no longer. But changing silo working and thinking does not happen overnight. We created in July. But that is the mission. This is probably one of the most profound changes in the NHS since it was incepted. And our job now is to make that feel right for our patients by making those pathways function in the way they deserve. We've never had that power to reach to all of that before. That is the duty we have in the roles that we have taken on, that we must deliver. But that's going to take time to get that message there. You will feel it. Or we cannot stand in these roles and these senior jobs doing this. So thank you for the challenge. We accept it.
And accepting that challenge, we thank you all for your questions. In the audience online, from the panel, this is a remarkable point in time, and we've shown what can be done through togetherness and focus in our pandemic responses. And my hope is that that builds into wonderful systems that really involve and serve our communities with the agility, the purpose, and the focus that is deserved. Thank you for listening.